Sit. Sit.
Oh yeah, but I'm gonna be facing the screen. Certainly does look like a smiley face, doesn't he? Oh, thank you.
If I may, after the information that we saw with you before, as you know, we asked you to have this scan done because the areas of the body can have different things going on, and this PET scan, which is a CAT scan along with the functionality scan, gives us a clinical indication whether there is potential for something unfortunate to be infection, inflammation, or possibly a cancer. CAT scan or PET scans will light up in any of these three places, but what you have to do when you see these is correlate the structure that's lighting up. In your previous CAT study that you had done, there was a mass, as you may remember, or your family may know, on the right side,
I was X-ray.
Yeah.
and it showed a rather large mass. And what I'm going to show you in a moment is the following. If you look at this, this is the CAT PET part put together. And what you're seeing here, for example, X-rays look at densities. So anything that is very dense, such as his spine, the bones of his spine, you can kind of tell. These are his shoulder blades.
Yes.
These are the collarbones, right about here. This is filmed as if your head is over here, and your feet are over here, and we're taking Houdini shots through you, so to speak. At this point, what we're seeing is, and these are your ribs, by the way. And the reasons we only see part of the ribs, because if you look at yourself in the mirror, your ribs don't go perfectly straight across. They kind of go on an angle. So as the slice comes through, it takes a little of this one, a little of this one, a little of that one. You can actually tell the computer, or the computer has all these slices put together. God bless the people who engineer this stuff. And every time I click this, we're coming 5 millimeters lower down the body, from the head all the way down. What we are looking at here, for example, are the heads of the clavicles, the collarbones. Right about here, you start to see the sternal body, which is the breastplate right here. So it tells you about where we are in the chest. This is the trachea, the main windpipe, so to speak, from the back of the throat that goes down into the lungs. Some of these other structures that you see here, for example, this is the carotid artery, the artery leading up into the brain. Gives the blood supply to the brain on the right side. There's one on the left side as well. These are the veins that drain the head. As we come further down, we start to see this structure, which is the aorta, the major blood vessel off the heart. This is actually the esophagus over here, the tube that brings the food from the back of the mouth down to the level of the stomach. This spot that you see here is the mass that we saw in your chest X-ray. And this is lighting up quite positively as what we would call PET positive. Strongly suggesting that this may in fact, the reason I say may in fact is, I don't know until we have a piece of tissue to confirm what it is, sir.
Will that determine the aggressiveness or the type of the tumor?
This tells us that you better biopsy something here to figure out what this is, because there's a very good likelihood that this is a tumor. Now, as we come through the rest of the body, you start to see that something else is lighting up here as well, and it's glowing quite bright. Lung cancers, or I should say the blood supply to the lungs, comes from the center area of the body. Much like, God forbid, a woman with a breast cancer tends to spread to the axillary region. What this is telling us is that there's increased metabolic activity going on in the lymph nodes sitting in the area of the middle of the chest. And that this mass, which is about 6 centimeters in size, may have in fact given off tumor cells into the lymph nodes in the center. As we come down through the rest of this, there are lymph nodes in this area as well, which are lighting up as well. As we come down further into the body, these are different chambers of your heart actually. There's actually something lighting up over here. Is there any, are you having discomfort at all in the bones?
Oh yeah.
That's why I can't sleep.
According to the written report, the destruction of the 5th and 6th rib.
Exactly right. And this may unfortunately represent bony metastasis. Did you fall or hurt yourself in any way on that?
I did. I didn't fall. I smashed into a piece of equipment on my job.
That's right.
But that goes back to September.
Probably unlikely related to anything you did, unfortunately, because this is a rather significant glow, as you can see. As we continue down your body, we are seeing here that there's a mass in the adrenal gland which is lighting up as well. And what this is telling us, by all indications at this moment, that it appears that you likely have a lung cancer that has in fact advanced to the lymph nodes and maybe advanced into other structures such as the bone and your adrenal glands, which is commonplace for lung cancers to spread. What we need to do at this point, I think, honestly, is get a piece of tissue diagnosis, because it would be our goal, if you choose to start treating you for it, but I'm afraid, surgically speaking, if this is spread to the lymph nodes, doing any surgery for you is not going to change your outcome. You have to control it systemically at this point. We always try to do surgery if we can, but if it is already spread to the lymph nodes, taking out the lung is not going to fix any problem
Yeah,
in that way.
it's just going to keep them on moving.
Exactly right. So what I need to ask you and your family to think about is that if you will consider doing therapy to treat this, and in this case, I say tentatively chemotherapy and radiation, and the reason for that is the following. The lung cancers come in 4 different flavors, kind of like a Chevy and a Ford and a Buick and I guess a Toyota. The most common is called adenocarcinoma, a slow-growing tumor, responds to chemotherapy nicely. There's one called squamous cell carcinoma, a little bit different type, tends to be in the periphery as yours is. It's actually responsive to chemotherapy and radiation therapy. We've had some people who have had squamous cell carcinomas, not that I want them to have a cancer, but sometimes if you have to have one, let it be that, because we had one person who had a tumor that was growing into their the nerves of their arm. We had biopsy-proven confirmation, and after the radiation therapy, we took the mass out, and it came back scar tissue. And I don't believe that it was necessarily scar tissue to start with. The biopsy showed, and it was behaving like a malignancy, but different tumors, like different cars, behave in different ways. So there's also a third type called an oat cell carcinoma. Usually appears in the center of the chest, not in the periphery as yours, and that one's very difficult because it has a very quick doubling time and usually is found in the brain. It tends to spread to the brain.
That's a non-small cell?
That's called small cell.
Small cell.
The adenocarcinoma and the squamous cell are the non-small cell. Oat cell or small cell are the terms used interchangeably. And then there's a large cell, which is a variant of small cell. So what I think you need, honestly, at this point is a tissue diagnosis to determine what this is. We have 2 ways of making the tissue diagnosis, and I'll give you the options. One, potentially, is to have the interventional radiologist stick a needle in this, on the side here, right, through the chest wall into this, and that'll likely tell us what's going on. The other one, and it depends on your breathing status, honestly, is to let me do something called a mediastinoscopy. The mediastinum is the central portion of the chest, and because we know what this is here, it is likely the same thing here. However, when you have somebody who has a mass, if you diagnose the mass, what we really look at, has it spread to the lymph nodes? And if we don't sample the lymph node, you don't necessarily know whether it's spread there or not. People who smoke, for example, and you and I have discussed what you smoke, can cause inflammation. So lymph nodes can light up positive in the presence of inflammation or infection or malignancy. What I'm thinking, or would like to ask you to consider, it's easy just to stick a needle in this thing, but if we assume that this is positive, then it takes you down one path of treatment. If it turns out that that's actually inflammation, but I don't know that it is, and I don't think that it is, because surgeons are pessimists, honestly. We're trying to expect the worst.
Where would that inflammation be experienced most? Trachea?
No, it would be inflammation in the lung that causes irritation that is drained by the lymph nodes, and the lymph nodes drain to the center. But unfortunately, this is where you have some enlarged lymph nodes. What I'm saying, honestly, is that there's a procedure called a mediastinoscopy where we take you to the hospital, put you to sleep for a little while, and basically make an incision at the top of the sternum here and slide a scope, much like people who had their gallbladders taken out laparoscopically. When you do it to the mediastinum, it's called mediastinoscopy instead of laparoscopically looking at the belly, the Latin term. And we would take a few pieces of this lymph node and send it for analysis, and by the time you're in the recovery room, we will know, is this a malignancy or is it not? Has it come from the lung? If it is a malignancy, then it tells us we have staged it. We have determined what we call the TNM classification: tumor, lymph node, and possibly spread disease. Sticking needles in people's bones or cutting out their bones of their chest wall isn't a very easy thing for most people to tolerate, honestly. We could stick a needle into this, but it doesn't give us the staging. Doing this, getting the results, gives us actually the staging, the tissue type, and allows us to get enough cells to actually do genetic markers, because cancer therapy has changed a lot compared to previous years. Before, when you had a diagnosis of lung cancer, everybody got the same treatment, but now that we know that lung cancer is 4 different types, treatments have evolved in different ways, and now, as you may have seen on television, with genetic markers, we can tell which people are going to respond better to one type of chemotherapy, which people may respond better to radiation therapy, And the treatment paradigms are getting more and more specific to the type of tumor. So what I would ask you to consider, if it's all right with you and your family, and I realize this is a lot of burden that we've put upon you, but it's a bit of a serious thing. Let us consider doing the mediastinoscopy and biopsy, which will allow me to get enough tissue to send for analysis. It'll allow me to know whether it's in the lymph nodes or not. And then you get as much, you have all the information that you take with you. If it is in the mediastinal lymph nodes, I'm afraid my role kind of stops there as far as any surgery, other than perhaps a port or something for providing access for chemotherapy. But it tells us that any further surgery on your lungs is not warranted at this point, sir.
Yeah, if you would do me a favor and take me back through that 5th and 6th rib. Because when I went originally to my GP, it was, please, I broke some ribs, get me a chest x-ray, and when the x-ray came back, total negative, nothing.
Well, because you may not have a fracture of your rib, but what you have is something with increased metabolic activity, suggesting that
They didn't even find soft tissue mass.
they may not find it, because this is actually inside the rib itself, inside the, well, if you look at the rib, it's basically
Hollow.
exactly, and this tumor is probably sitting inside the center area where the marrow would be in the rib.
And
You can
that
see
would
it's
encompass
lighting up very
both.
specifically here.
Because that's what he has so much pain. It's terrible.
This suggests, I mean, if you wouldn't mind, if you want to take your shirt off, I'd be glad to look at it, but if I can
Yeah.
feel a mass there, we could basically,
Oh, you can. If you don't mind
No,
getting a
of course.
little muscle rub on you, or
it's
lidocaine,
okay.
right up in here. Oh, yeah, all up in there.
Well, what I can tell you, you can feel this right here. Now, the bone is a little bit of a hard thing to biopsy, but what I could potentially do, with your permission, is take you to the OR, put you to sleep for a little while, make an incision right here, and go down to where this hard bump is. And what I can do is try and take some of this and send it for analysis. And if the biopsy comes back, unfortunately positive right here, we stop. We're done. It stops me from going into here. It stops me from doing anything invasive.
It's made itself available and conveniently in such a place that
Exactly right.
you'll be able to get a determination if they're all in the same family.
Well, if they identify this and it comes back malignant, with all due respect, I would stop right there. If they look at this and say, no, we don't see any cancer cells, well, with your permission, in the same setting, it doesn't make sense to put you under multiple anesthesias. We would consider making that small incision here, getting the tissue diagnosis, and moving forward.
Back in 2003, I had prostate cancer. The attending anesthesiologist came to me outside in the anteroom, pre-op, and he introduced himself and told me that he'd be doing the anesthesia. He said, I've reviewed your x-rays, and I'm not going to be able to give you a general.
Did he say why?
He said, the condition of your lungs is what he said. So he said, I'll give you a spinal, and they went through with the operation, which is brachytherapy seeds, irradiated seeds.
How long ago was that surgery done, with the brachytherapy?
2003, November.
Have your PSAs been normal since then? Did they say it was anywhere else besides just the prostate at that point?
No, the PSA remained. It was at 4 when they grabbed it. I was 59, on the cusp of 60. And the watchword then was PSA, the levels of the antigens. My physician gave me a DRE, and he said, oh, I suspect, I feel a lump. And
Where?
on the prostate,
Okay.
at the apex.
Mm-hmm.
So I followed it up. I went to the urologist. The urologist did the same DRE, and then he gave me his opinion. He says, I want you to go for a biopsy.
Yeah.
So he took 12 core samples, and they found it in one place at the apex. And
Have you been following up with them since that time?
I've gone back as late as a year and a half after the operation, back to oncology, and the man told me it's been perfectly normalized.
The reason I ask is that many different tumors can spread to different places, and prostate is one tumor that tends to spread to bone. Honestly, it doesn't tend to spread to lung. So it is possible, and again, I don't mean to sound like a stupid broken
Yeah.
record. That is a suspicious lesion. It is PET positive. It's something that should be biopsied. It may be from the prostate. It may be from the lung. I don't know until we take a piece and send it for
Well,
analysis.
it's what it is from where it came.
Yeah. So again, to the best of our ability, if it's something that you feel is appropriate for you, and that your medical doctors feel your other systems are stable, need to get a piece of tissue from somewhere. This would be a lovely and easy one because I could probably, with some, dare I say, intravenous sedation and some local, probably get down to that relatively easily, take a piece of it and send it off for analysis. If it didn't come back as anything conclusive, we may have to do something further. You may say, while I'm there, just go and get what you have to get, so to speak, to get moving on. And those are the two options I can give you. If your medical doctors feel that you can't tolerate any kind of anesthesia, then I have to be honest, then I would probably say, let's just do a needle biopsy of the mass that's right under the ribs. And we'll
You
take
could
it from
practically give
there.
me Benzacade or
We could
Novocaine.
just give you local, turn you on your side, and with a CAT scan guidance, they can pinpoint the exact spot and put a needle right into it.
That's,
The only thing it doesn't stage it for us. But if you're comfortable being treated that way, and I personally I am okay with it as well, we can just do the needle biopsy and see if the oncologists are comfortable.
if it
treating
is
that way.
cancerous, why are you unable to stage from it?
Well, because staging by definition is to evaluate the tumor and/or the lymph nodes. If you have a lung mass which is PET positive and you find it in the lymph nodes, it didn't spontaneously grow in the lymph nodes. Likely came from the lung mass into the lymph nodes. So that gives you the staging, the tumor as well as the nodal status. Staging is complete when you have tumor, nodal status, and any events of spread anywhere else. That's the TNM classification of how lung cancers are staged. If you biopsy a lung tumor, but you never check the lymph nodes, then you kind of know what you know the type of cancer it is, but you don't know the true staging 100%. Yours, I suspect, may be advances based on these findings, honestly. So if your breathing is a consideration, number one, it should be make the diagnosis and don't harm the patient. And it would not be unreasonable based on these findings to potentially just treat it in that manner. By the book, if I may say, and I think the books are written for a reason, you really should, we typically go to the lymph node because that gives us the true TNM classification. But if your breathing is a concern, I don't want you to end up on a ventilator that you can't get off of, for God's sakes. We'll be glad to do something less invasive.
And how soon could that be scheduled?
Are you taking any blood thinners, aspirin, Plavix? Coumadin?
No. I have been overtaking acetaminophen because with this pain, and this is a considerable amount of pain and discomfort, I can't seem to sleep.
Yeah. I think the answer, honestly, is at this point, what I would need to do tomorrow, with your permission, if the needle biopsy is the way you want to go, and it's perfectly fine, honestly. It's usually done by an interventional radiologist at the hospital. I'd have to give them a call. They may wish to review the films and probably be done within the week. And that may be the best. God forbid this young girl ever had a problem. Well, we could put her to sleep, do the whole thing, and at the end turn off the anesthesia and she'd say,
She
I'm out of
that's
here, I'm fine.
72.
You get to be my age and your age, we need to be treated with a little bit more respect and a little bit more concern.
No, I know
I
that.
am a grandmother.
You look pretty damn good
Well,
for
so to
grandma.
qualify. I'm a grandparent.
So the answer is, it's a concerning PET scan. We need to at least find out what we're dealing with, and based on these findings, once we know what it is, if the oncologist and you are comfortable moving ahead, the suggestion is that this is a disease that I can't fix surgically to cut out for a cure.
But you'll be able to tell if that lump is prostate related or...
Well, I
It'll
can do
say
that only
something.
if I do the biopsy of this. Now, what I will say is that if they're going to put a needle over here, they may be able to get a needle into this mass or a core biopsy, and I can't promise you what somebody else is going to do until
Yeah.
they try.
Yes.
And that's why it's worth asking them, because they're doing something superficial that really doesn't suppress them as far as it would be for me, who would be giving him more of a systemic anesthesia. If they can get the answer without beating him up too badly, we can do it that way. If they can't, well, we can say that we tried to be as cautious or we tried to be as conservative as possible. We need to do something a little bit more invasive so that we're be right with everybody.
Well, again, I'm not looking to get hooked on painkillers, but I have to ask
If
you
this
this.
is a bone met and it's coming from, God forbid you should have a squamous cell, but I have to be honest, if you have a squamous cell carcinoma and it's going to the bone, this will get better with radiation therapy. It'll shrink the whole darn thing and your pain will go away. So we really just need to get us an answer and see what the hell we're dealing with right
So
now.
what I do in the interim, suffer with the pain?
Well, I can give you some pain medication, but I'll be honest, it's not going to do a lot for you because right now there is something just literally tearing that bone apart, going inside of
The
it.
only thing that's subdued is a cough that's been going on with me too.
Part of the cough is because what's going on in the right lung right
Well, part of it is the flu bug. My,
now. Yeah.
my wife is
Maybe the
getting,
flu bug, but
well, everybody I know on the job.
I can give you some pain medication that basically just suppresses cough and makes you kind of dopey in the head. But if you need some, I'll be glad to
To help him
provide.
sleep. He's
Okay.
not, he's not sleeping.
He's up a lot.
Let's do this if you wouldn't mind. What is a good number to get a hold of you at?
My home telephone number,
Okay.
area code. It should be on the, if you,
It probably is, but do you want us to call you, or you want me to have my scheduling secretary give you a call tomorrow? Think about as the family what you want to do, or most importantly, you as the patient.
631
Mhm.
226